Germany and France will soon join Israel in rolling out a third booster shot for COVID-19. They're pushing ahead with the plans despite an appeal by the World Health Organization to wait until more people have been vaccinated worldwide. The countries intend to give the doses to the elderly and other high-risk groups as early as September. The WHO said this week that it's unfair for rich nations, which are already ahead in vaccinating their populations, to take up millions more shots, which are needed in Africa, for example, and other poor parts of the world. Let's talk about South Africa and booster shots then with the head of the country's Ministerial Advisory Committee on COVID-19 vaccines, Professor Barry Schoub. Prof, always good to speak to you. Welcome to Newsfeed PM. Is it too soon for South Africa to start discussing the third booster shot issue?
I think it probably is too soon. I think we really need to kind of get as many people vaccinated as soon as possible. I think that really must be our first kind of aim. I think if we can stop the virus circulating by getting as many people immunized as possible, we will, decrease the load on the healthcare system. And I think that's really what we're trying to achieve. I think the issue about booster doses may come in for those individuals who have not responded to the vaccine. That may be people whose immune system is suppressed because they aren't going to respond as well to the standard dosage of vaccine, and of course the elderly as well, because they are at higher risk. But I think for the general population, we really can't at this stage think of booster doses.
And just on the issue of people who you say their systems may not have taken to the two doses in the case of Pfizer, for example, or the first dose of Johnson & Johnson, which is a single-dose vaccine. How would the assessment be made? It's easier, I suppose, to look at it according to age, but more broadly, how do you see whose immune system has not responded adequately?
Yeah, I think we know from experience that people, for example, let's take the one extreme, people who got solid organ transplants, they had a heart transplant, a liver transplant, and so on, who are on high dosage of immunosuppressive drugs because of the transplant. We do know that they don't respond well. It's a very small number, so it's not going to really affect the vaccine rollout to any significant extent. That's one extreme example. The other example, as you said, are the elderly and maybe the kind of on the extreme of ages, from the 70-year-old upwards, 80-year-old upwards. We know that they also don't respond as well to the regular dosage of vaccines. And again, it's not going to be a great number of individuals, but really the kind of main aim of the vaccine is not to look at boosters at this stage.
And on that point then, Pfizer said, I think a week and a half ago, that they were going to apply for emergency approval for a third vaccine dose in the United States. The authorities then in the U.S. responded saying, well, no, actually, the scientific data available currently does not suggest that there's a need, because even on the two doses as originally planned, efficacy has been found to be in people above 70%. So is it necessary even globally?
Yeah, you're right. There have been a number of studies even in some in South Africa, some in the States and elsewhere, where they've demonstrated that the immune response is pretty high, even as far as 280 days. That's quite a long time, and it's a very good vaccine. Let's face it. But the problem is there are what we call breakthrough infections. It's not a perfect vaccine, but fortunately, those breakthrough infections, in other words, the infections which occur despite vaccination, in the vast majority of cases are mild. So it is to some extent a tolerable situation. But even then, it's probably over 90% of individuals will be protected. But there will be a certain percentage who won't be. And I think this is where that kind of motivation is coming from to have a booster. The only thing is that the scientific data has shown that the booster in the majority of healthy individuals doesn't really boost very much. The immune response is really at a fairly high level anyway. And the third vaccine is not going to tip it higher than that to any significant extent. So the need for it is, in most healthy individuals, is not strong. It's only really strong for people who don't respond well to the vaccine.
And I know this has been discussed a lot in South Africa in the past year, but remind us again, Prof, of what an adequate level of protection from a vaccine is.
Yeah, it does depend. We've got excellent vaccines like measles vaccine, for example, polio vaccine. Those vaccines have been extraordinarily effective, well over 95% protection against disease. Now, the COVID vaccine is not quite as efficient as that, but if we're looking at at the level of protection against severe disease, in other words, disease enough to land people in hospital, that's well over 90%, 95% for both the Pfizer as well as the Johnson & Johnson vaccine against the Delta variant, which is a variant which is circulating at the moment. So that's the level that we can expect for the main aim of vaccination. To protect against mild to moderate disease, it drops quite a lot. It's anything from 60 to 70%. It does depend where these trials are done, what kind of population it's done, and what endpoints one is looking for, but approximately 60 to 70% against mild to moderate infection. That means that there's quite a gap of people that won't necessarily be protected against the milder forms of illness, which can be yeah.
Pardon me, Prof. Is it then time to start having the discussion about how a COVID-19 vaccine may have to be part of what many of us factor into the annual trip to the doctor for a checkup or the annual trip to the clinic down the road?
Correct. I think certainly boosters will be required in time. We know that the kind of immunity which is elicited by these vaccines to protect the respiratory tract, where the virus enters into, is not going to be all that long-lasting. We know that there will be a need for boosters. It may be annual, maybe every 2 years. It's a bit early at this stage to kind of assess the kind of frequency. But I think what we do know is that there will be a requirement for boosters in time.
And it was interesting this week to see the reaction from the Americans to the WHO saying, hold off if you are a wealthy nation that's far ahead in vaccinating your population, because there's a situation where in Africa, for example, we've managed to vaccinate such low numbers of people, right? The Americans then responded, said, well, no, this would not disadvantage the vaccination of people in poorer countries. We've got enough stock to vaccinate our own populations and still make donations to the likes of Africa, as we've seen in South Africa, for example, in July. Yeah. But that itself, that admission, speaks to the fact that they've simply bought more than they need.
They did. Certainly in 2020, when they ordered vaccines, they overbought, sometimes to three to 5 times their population needs. The only thing is this, with the WHO call, one has to kind of also analyze if these wealthy nations do stop boosting, for example, either boosting or immunizing, say, younger individuals where it's not such a clear, important issue, the children and so on, or giving third doses. Will that, in fact, increase vaccine coverage in the poorer countries? Is the problem in the poorer countries the supply of vaccine, or is it the actual distribution and administration of vaccine? And I think this needs to be kind of clearly defined, before one can say, right, if the wealthy countries did stop with their boosters, will that in fact increase vaccination coverage in the poorer countries?
Professor Barry Schoub, head of the Ministerial Advisory Committee on COVID-19 vaccines. Always a pleasure to speak to you, Prof. Thank you.